Today is going to be focused on, from my perspective, a little bit more information around clinical trials and research. We will also be creating a document, and so I'll be working with Nicolette, Tiffany, and Dr. Cloth so that we can get those tools and resources to you and at your fingertips. Let's see why my screen is not moving. Oh, there we go. All right. So research, that is one of the main things that we are known for at the Alzheimer's Association. While we've been successful in scaling up our NIH dollars for the Alzheimer's, there are some drawbacks. For one thing, the NIH really only funds research in the US, and we know that there is a lot of research going on globally. But private philanthropists can fund anywhere in the world, and the best projects, regardless of where they're happening, we are supporting them. So when we look at it today, from our perspective, our contribution is more than $208 million in grants in force to making this possible with more than 590 projects in 31 countries. So again, while we have the NIH grants and funding for research, we as an organization are also contributing to those projects. One area that we promote, and so Dr. Cloth will talk about it from, what are available in NIH grants. We have specifically to matching for the association, what's called our signature, our trial match. So trial match is a service that provides customized lists of clinical trials based on users' provider information. So one thing I think that's really important when I say that is that when somebody goes on to trial match and they're looking, they put in their demographics, that information is not given or distributed to any of those research organizations. What it's doing is populating what you would qualify for. So it's really an easy platform to use. It allows you to look and see what research studies are being done, what are some good fits, is it a good fit for you? Is it somebody that is specific that's living with dementia, or their caregiver, or even healthy volunteers? So what's nice about going to our trial match is it's not just specific to somebody that could be in that MCI phase where we're looking for a clinical trial. We're looking for healthy individuals as well. We're looking for caregivers. And what we're finding more in the research we're doing today, not just from the therapeutic approach, but also around healthy lifestyle. In July, we'll make sure that everybody gets the link to attend. It's going to be free still again this year, and on a Zoom platform for our AAIC, which is where globally we come together, we look at research, and this year is really focused on healthy lifestyle. The Alzheimer's Association also has our Science Hub. Really encourage people to download that app. Why I like that app is it gives you real time of things that are happening. Sure, Dr. Cloth, I don't know if you're going to talk about it. I don't know if you want to nod yes or no about what's coming up here in early June and the potential with our first ever treatment, aducanumab. And so I really encourage individuals to download this hub and learn in real time what is happening around this new treatment, as well as other blogs. And it really gives you information from our organization. As a global leader in Alzheimer's and dementia science, the Alzheimer's Association shares the latest research and trusted perspectives. So when we look at the work that we do, it's really around the concern and awareness. We lead the way to end Alzheimer's and other dementia by accelerating that global research, driving risk reduction, early detection, and maximizing quality care and support. Our vision is a world without Alzheimer's disease and all other related dementia. To maximize quality care and support for all affected, the Alzheimer's Association provides direct services through the telephone, in-person delivery, and offers education for support, and also with our early stage programs, all of it free of charge. So those are some of the things I talked about earlier on, and they'll also be provided to you as far as links that you can use as tools yourself, as well as for those that you're providing care. Our work in health systems is around the importance of timely detection and accurate diagnosis. which have been the last two parts. And Dr. Gloth is going to talk more specifically diving into behaviors. Advocacy. We also cannot do the things we do without our advocates. We've seen a lot of movement happening here in the state of Florida, lobbying legislatively, not only in the state, but nationally. And that's where I really bring up to people that we as an organization have changed from being a social supportive network to a public health organization, really getting ahead in the timely detection and diagnosis. And that is, again, more evident why we need to get earlier on is in June, if we do have an announcement of the first treatment ever, that medication, that treatment can only be done in the early phases of this disease. And that's why we really need to get ahead of that. As always, I like to share our 24/7 helpline. Please make sure you write this phone number down, put it in your phone. You know, alz.org is there for you and those that you're serving. And again, I want to thank you for your time. We do encourage, so we've done these 3-part series for you. We do encourage still the use of our Alzheimer's and dementia platform. It is a 12-session program. Each hour we do provide CE and CME for our providers that do participate. You've seen some of the case studies. We're going to hopefully do one of those case studies later on, but it really is with our subject matter experts supporting you and how you are supporting your patients and their loved ones. So I'd like to turn it over to Dr. Gloth.
Great, thank you. All right, see if I can grab a slide here. All right, so try this again. There we go. So we'll talk a little bit more in terms of this issue that we have with dementia. We've talked a little bit about the different types of dementias previously, about the workup that's being done to determine whether or not somebody has a reversible versus an irreversible dementia. In this slide right here, you can see that there are a variety of different types.
We're not seeing it. We're not seeing anything yet, Dr. Gloth.
You're not? Oh, let's work on this a little bit more then. Hang on. Oh, it says I can't start this share screen while somebody else is sharing. So, Dan, are you still sharing?
I am not.
Oh, here we go.
Okay,
right.
I just clicked a button, so I don't know if that helped.
Whatever
Sorry
you did,
about that.
it's okay, no worries. Okay. Everybody should have it on their screen now, yes?
Yes.
Okay. So where I was with this is the different types of dementias. We talked about reversible versus irreversible. Because of the shorter time last week, we didn't get to really talk about distinguishing between one type of the irreversible versus other types of irreversible dementias. The most common, of course, is Alzheimer's disease. And this table gives you some of the key factors in terms of the anatomy of the deterioration of the nerves in the brain. Talks a little bit about what you see with regards to the history and some of the presenting symptomology, as well as some of the exam findings that you may have. What you'll see with Alzheimer's disease, generally it is a global disease. You'll see predominantly the medial temporal and the parietal lobe atrophy that is very distinct in terms of imaging. We talked about not necessarily getting PET scans on folks, but when you do that, you're looking for amyloid in particular. And for most of the patients with Alzheimer's, you'll see an increased accumulation of amyloid, although we do know that you can have amyloid in individuals that have no symptoms of Alzheimer's disease. We have certainly vascular dementias, and there's a lot of cardiovascular disease in society. That follows more of a stepwise progression, if you will, where people do pretty well for a period of time, then they'll have a sudden decline. They won't really get back to their baseline, and they'll continue to decline in a more stepwise fashion. distinct imaging changes that you see, particularly when you do an MRI, where you see the white matter lesions, particularly subcortical infarcts. Frontotemporal dementia, as the name implies, is mostly in the frontal areas where you see much greater atrophy, as well as in the temporal lobes. These folks often have behavioral problems. They have very refractory depression. They can have abnormalities in their gait as well. The Lewy body dementia, those patients present somewhat similar to Parkinsonian types of changes. They may be slow in their movements. They may have visual hallucinations. Usually when they have hallucinations, they're seeing things that are small animals, children. They may even tell you that they see elves or something like that. But generally, those hallucinations are not disturbing, but sometimes they are. And when they are, they may require more aggressive intervention in terms of antipsychotics. But usually you can get away without the antipsychotics in those individuals. You also will have those individuals early on having spouses complain that they are very active in bed, that they're running in bed, or they're acting out their dreams while they're sleeping. Most of us may have a little eye flickering when we're dreaming, but we don't act out the dream. That is a distinction that you see that is a hallmark of Lewy body dementia early on. Parkinson's, I think most of us are familiar with Parkinson's disease. Usually the physical presentation occurs much earlier than the cognitive decline in terms of thought processes. But the micronaphia, the small writing, the slow gait, the difficulty in initiating gait, those are all things that are hallmarks of Parkinson's. Usually with Parkinson's, you'll see those physical features before you really see most of the dementia features. Then there are some things that we need to consider in terms of terminology. Certainly there are some normal aging changes. I talk a little bit about cognitive overload. You walk into the room, you've got to go to the bathroom, you've been shopping, you put the groceries down, you throw your keys somewhere, you get to the bathroom, you come back, you put your groceries away, you get distracted by a telephone call, you do something else, and then you realize you need to go out and run another errand. You don't know where you put your keys. Well, that predominantly is related to lots of things on your mind and the lack of focus in terms of where you put your keys when you didn't put them in the spot that they are supposed to go. That is a normal part of the aging process. Everybody has that. There is no reason to be really concerned about that, although some people are concerned about it. Name finding or recall of names, by the time you get to be 70, 80 years old, you've accrued a lot more names than you have when you were 6 years old. And I often share a somewhat humorous story about being in a grocery store and talking with one of my colleagues and having my 6-year-old daughter with me and telling her that I couldn't remember the individual's name, so I didn't introduce her. And she was terribly puzzled by that because she thought she could remember all her friends' names and couldn't understand why her father couldn't remember one of her friends. And I explained to her that by the time she got to be my age, she would have a lot more friends and have many, many more names to remember. And sometimes out of context, it's more difficult to remember them. And that was somewhat acceptable to a 6-year-old, and I hope that that's acceptable to most of us as well. Delirium is something that I described last week, a patient that we had that was admitted to our memory unit, had guardianship papers all drawn up. The courts had declared that they didn't have capacity. Well, we declared they didn't have capacity, but they didn't have competency, the legal term. And we had to go through a tremendous amount of effort to get that reversed. And it took probably 10 days in our memory unit when this gentleman was actually quite normally mentally after his delirium dissipated. And yet in the hospital, that delirium that had been confused with dementia led to guardianship proceedings, et cetera. And unfortunately, this very reversible problem that completely resolved wasn't so easily resolved for the gentleman who couldn't go home until the judge declared that he continued to have capacity. And we had to work with guardianship folks and get a number of physicians from the state in to interview this gentleman before we could send him back home. So it is important to pick up those reverse. Yes?
I have a question. I was in a caregiver support group meeting on Tuesday night, and a couple of people were talking about how they've seen in their own family, or they've just heard from others, that like post-surgical delirium, like after someone has a major surgery, like a hip replacement or something, that they find that either causes like a sharp decline with dementia, or maybe it's a delirium period. How can you differentiate that? And like, what's the treatment for that acute issue post-surgery cognitively?
So delirium can last up to 6 month period of time. It is often triggered by medications, particularly those that are used in surgical procedures.
Okay.
There are steps that can be done prior to surgery to help reduce the incidence of delirium postoperatively, and also the selection of medications and having things that help an individual in terms of orientation while they're in the strange environment of the hospital all can help reduce delirium. A lot has been written about delirium, not just assessing it with a CAM in the hospital, which most hospitals are starting to do, but also how to reduce the incidence and severity of delirium. And so it is important to recognize that that is a factor that's out there, that it can last for a prolonged period of time, and taking steps to try to reduce the incidence. In terms of mild cognitive impairment, we talk about this a lot. It is more useful in our discussions, as we talked about earlier, when we're telling somebody that they may have some changes mentally, particularly when we think they're dementia. Dealing with the term mild cognitive impairment is much more palatable for most of your patients than will be dementia, even though most of these cases of mild cognitive impairment progress to some type of dementia. Maybe half of them or more go on to Alzheimer's disease, but many of them lead to other types of dementias as well. So last time we talked about medications that are out there. Predominantly, we're dealing with memory symptoms, if you will, trying to give them medications that temporarily will improve their memory. Even this new monoclonal antibody that's been identified to help reduce the cellular debris, if you will, reducing amyloid and other factors that exist in the brain related to cellular breakdown. These are not permanent solutions. These are not cures for dementia. These are things that we hope will slow down the progress, and they are, the studies that have been done with these drugs are most effective early on in terms of slowing the process down a bit, but it will still continue. They'll continue to lose neurons, and we really don't have a cure. And until we really understand what the etiology is, it's going to be hard to have a treatment. And because of that, we're going to rely really heavily on caregiver support, behavioral interventions, as we talked about before. One of the things that I will say in terms of the treatment is that once you make the diagnosis, these folks are in a very different place compared to our reality. And it's important for us as we interact, whether it be in the office or whether we interact with them in an institutionalized setting or even at home, that both our staff and caregivers recognize how important it is to sort of transport ourselves into the patient's reality. So I tell a lot of folks in the memory unit, you have to introduce yourself to a patient every single time. So you go into their room, just as you would be upset if somebody walked into your room, they'll be upset if somebody walks into their room. And they'll be more upset if it's a stranger. And if they don't remember who you are, you're a stranger. And so that is really important. One, that we make sure they're comfortable in the environment and that we reiterate what the purpose is of our visits. And also important that we don't tell them that they can't do things or use the word no for them a lot. They're adults and they have the same perception of themselves as we have of ourselves, and they don't recognize that they have dementia. And so if I were to tell you, no, you can't leave your room or you can't leave your house, you'd be pretty upset about that. If I told you that your mother wasn't alive and you thought your mother was alive and that you had just seen her a few days ago, you'd be really upset with us. And so it is important to recognize those factors as we deal with individuals that have cognitive impairment, and that we work to make sure that we are cooperating with their thought processes, that we are helping them to accept whatever is going on. And if there are things that they can't do, we have to redirect them. We can't tell them that they can't do it or even try to explain why they can't do it. So that becomes very important in terms of behavioral management and redirection for folks, so that we don't get into a situation where emotions start to escalate and they become very difficult to control and very disruptive. It's important to educate the families about that as well. And so support groups that are out there that can do that, whether they're online or in person, doesn't really matter. But having opportunities to share that information with people who have gone through it and have expertise in the area becomes very important for people who are dealing with it for the first time. Advanced directives we talked about as well as being very important, particularly early on when you make the diagnosis. So in terms of patient and family education, getting them to have a skill set that helps them manage the patients, recognizing that there's no Machiavellian intentions coming from a person who's demented. Those individuals that have cognitive impairment, they don't have the wherewithal to do something intentionally to manipulate or to try to have a specific psychological impact on somebody else in the family. They're not doing things on purpose to manipulate them. And that's important that people understand that and work with that. They also need to understand that they're going to have to repeat the same thing probably 20 or more times during the course of the day. And they don't want to raise unnecessary challenges to an individual. So you're not arguing facts and the fact that you know what's going on and they have cognitive impairment. That's never the goal, is to convince them that they don't have the full control of their faculties. You're always working with them to try to get them to a point where the facts that they have as they see them are things that work to your advantage in terms of helping to guide them into a direction that's fruitful and safe for them. Focusing on the individual person becomes really important and not the disease. It can't be, this is an Alzheimer's patient. This has to be, this is a person who is going through some difficulty in terms of their cognitive ability, but it is not so much that it is a real issue in terms of continuing to focus on the disease. What we need to do is focus on what they can do, and we need to focus on optimizing their appreciation and quality of life. I usually recommend to people, patients, family members, not the patients themselves, but to read The 36-Hour Day by Nancy Mace and Peter Ravens, which gives a very good overview and appreciation of what to expect as an individual goes through dementia.
I would can I add something about the
Sure.
focusing on the person? I think really considering, what did they do for their career previously? What's most important to them? Is it what, like identity wise? Is it being a grandmother? Is it being a volunteer in the community? And just trying to find ways to integrate purposeful activities and engagement, like something that aligns with what they care about and what they're used to. Also can help in identifying behavioral issues. Maybe it's related to something they did for 40 years for their job, and now they're kind of automatically still doing that. So it does require some detective work and being creative to find like what would be good for that person. But what we promote in a lot of our trainings is all around purposeful engagement. How can they contribute to the household still? Like what aligns with what they care about as an individual? So just helping families even just consider that quickly in a visit might be useful.
That's a really good point. And it doesn't have to be, you have to know their whole family history or their whole life history. It can be little things that are triggers for them to which they can relate. I know I have a particular patient, every week I see her, and every time I see her, she of course doesn't remember who I am, and I introduce myself, tell her how nice it is to see her again, ask her how her son Jay is. As soon as I say the words, your son Jay, she immediately lights up, her personality changes, and she recognizes that I am not an adversary. She recognizes that I'm not a threat. As soon as I say those words, she has a total change in her persona, and her body language changes. And it's a very simple thing, but I can do that every single week. I don't have to think about anything else. As long as I say, how's your son Jay doing? That's something that is a trigger for her. And you'll learn those kinds of things as you deal with individuals as they have dementia. And pick on that, maybe even put a note in your notes that reminds you sometimes if it's a person you're not going to see on a weekly basis or even once a month. but recognize that a lot of times those little triggers will help you out a lot when you're interacting with somebody. The recognition that caregivers really play a major role in terms of dementia with our population is important. We had a law signed in 2018 specifically identifying support for families, and it directed the Health and Human Services to develop a national strategy to provide education, training, long-term services, supports, and financial stability and security for caregivers, and make recommendations to Congress. Those recommendations hopefully will continue to move forward under the current administration, and that will be something that will be embraced by Congress, and we'll see some additional funding that goes out that support caregivers, which of course is a major economic help to the nation, because those caregivers who are at home taking care of people with dementia means that we don't have them institutionalized, which of course saves billions of dollars a year for the nation. But they do need support. Last week I gave some websites, I'll give them again. This just helps folks. You certainly got some information from Deanna a little sooner about the Alzheimer's Association. They have lots of resources that are out there. And then the UCLA site in terms of caregiver training videos, those are very helpful for new caregivers of people with dementia. Here is another website. This is NIA, and they have information in terms of research and funding that is out there for dementias. You'll see at the bottom the alzheimers.gov clinical trials finder. Any clinician can go onto there. Actually, anybody can really do this. And you can find out about the clinical trials that are available for patients that you have and whether or not they might be eligible, where they're located, where they're recruiting. So if you want to find something in your area, that's a good place to go, or even have family members keep an eye on that site in case there's a research trial that comes their way that might be appropriate for the individual for whom they're providing care. So in summary, we talked about lots of different types of dementia. While most of them are irreversible, there is a little bit of change in terms of how to identify one form versus another. Mostly this is useful in terms of prognosis, how fast somebody will deteriorate, whether or not they will be able to be independent or be able to live at home for a prolonged period of time. Different types of dementias progress at different rates, and sometimes they're even subsets. So if you look at things like progressive supranuclear palsy, for example, 20% of those individuals will survive 7 to 8 year period of time, where most people with PSP will only survive for 3 or 4 years. And so recognizing that there are different elements out there and working with the family and identifying one type versus another, some of those clues that I gave you in those charts earlier will help you with that process. And then certainly we emphasize caregiver support. I think now you have lots of resources in terms of caregiver support. Nicolette may talk a little bit more about that when I finish up here. But the main thing is that lots of research is needed. We really need to understand what causes these various types of dementias, how we prevent them, and how we treat them when they do occur, and what aspects require different treatment at different stages as we go through the process. So lots to be done, a very costly disease process, but something that we're all going to have to handle, whether we're dealing with individuals as a caregiver or whether we're the healthcare provider giving guidance and oversight to those caregivers or the individuals who have early diagnoses. So that should do it for me. Let me open it up and ask Nicolette if she has something else that she wants to say. And Dr. Carmichael, I want to hear a little bit from you in terms of whether these presentations were useful, and I'll let Nicolette guide that a little bit more as well. Thank you.
Thank you, Dr. Gloth. Really incredible summary of all these different facets of dementia care. I could talk about different issues of how to support caregivers, what's out there in our region. I love promoting the helpline for 24/7. The Alzheimer's Association's helpline is good for people. The Alzheimer's Project, Doris, they're a local nonprofit. They have respite sites. They have case managers. If you have a patient that just needs a lot of different nuanced support, have them call one of their social workers and just answer their questions, help them navigate kind of our region's resources. I would love for y'all to utilize them as a partner a little bit more than at least what I've heard. But yeah, I'd love to hear from you of questions you have, if there's any unique cases or anything, or just general feedback that you have for us about this experience.
Well, I think it's a perfect timing for the class. These last 2 weeks, I've had even more cases just like this, permanent or reversible dementia versus a delirium versus, so I've had quite a few of these patients the last couple of weeks. I told my staff, this has got to be karma going right here. And just like Dr. Glock mentioned, I had a few that one was a pacemaker insertion and went back within a week, chest pain, back to the hospital, stent placement. So the events, the stress of on the body and the mind with those things happening, the change of environment, delirium, the family's very concerned. She's very confused. She lives alone. We're here visiting. What happens? And so we did have to talk about how these things can cause a reversible issue that will go away with time. Structure and maintaining that routine helps a lot, makes a big difference. I had one in this morning, and it never fails to shock me how we have these conversations that, you need to go ahead and look at a power of attorney, and you need to look at legally assuming some of these responsibilities. So when I see these changes coming, I shorten the frequency of their visits so that I'm seeing them instead of, every 6 months, possibly to every 3, or even monthly, depending on what's going on. And so now we have daily sitters, and she's forgetting her insulin. And so we have, those medical conditions just complicate an already confused patient. So today I'm like, have we gone through the legal process? Are you power of attorney? And no, we haven't. And I'm like, we're probably too late for this now. Now it's going to be really complicated. This has really helped. I think we as medical providers really need to be proactive and educate the families on what's coming and help them maneuver and navigate through this. I realize we may, in my office, I see them for 30 minutes, 45 minutes, an hour, but they go home, they take them home, and 24/7 is really
36-hour day.
Yes,
Yeah.
it is.
Demanding.
Yeah, it's tremendous on the family. It really is. And I know they want to keep, I got a letter this morning. A husband sent me a letter. This was a ischemic issue. I did a CT, and I said, because it was mental status changes. So you work through the differential, with these older people, UTIs, blood work for chemical, you work through it. Did a CT. There's our culprit, so he's like, I want to keep her home as long as I can, as long as she's safe. And so now we're having that conversation. I'm actually doing a telehealth with him this afternoon. How can I help you? What support systems can I give you? Because if she's 80, he's 80,
Yeah.
So you're no longer just taking care of the patient, you're taking care of the family, really. It gets really complicated, and I'm in a family practice setting, so it's not a specialty care, and those guys are great when you need them for confirmation of things, but it's really this has been very vital. I'm glad y'all recorded. Now I'll be honest with you, I'm a little confused as to why only a few of us are participating. But I think it has something to do with some of the programs we were working on earlier in the year with the medication, with the Medicare annual wellnesses, and how we were evaluating that process. I would love for all of our centers to participate and see this. It's very important. It's just very important information.
Yeah, thank you.
You won't get a judgment from us.
Yeah, we're hoping that this will be what we've done, Doris, with the grant is focused on a couple sites at a time rather than like every single site. So we're going to move on to WEWA and Madison. So we'll hopefully build this into their program and, have Deanna and Dr. Gloff accessible in some way. But we are so grateful for you as a champion of this sort of care. And I'm going to ask you too, maybe, and I'll work with Dr. Brown and Lane about this at the provider retreat in August. I think that's a good opportunity to get in front of all the different clinic sites, and perhaps you could share some success stories or things you've learned and discovered like through our training partnership. But we just so appreciate your input and your attention and all the care that you're providing to your community.
Well, I think Dr. Brown had asked me, because I guess they were doing report cards on some things and looking at the Medicare and your wellness, and the 65 and over population needs special care. There's special things you just really have to look at. And so he's asking, how do you do so? I said, well, there's a template built in the system. If you use the template, it will red flag and trigger things that you really, and if everything looks fine, then you move on. And then of course that physical assessment really makes a big difference. I think it's important to do those. Now I can tell you, even after our little virtual visit we did here, there's a few things that I have implemented here with the help of some equipment, the hearing devices that we have. I just got a new chair, with arms, and you know this stuff, but I just didn't really. It has made such a difference. My patients are asking, "Can I go to that room?" Because I only have one in the one room, and so now some of my olders that use cane or walkers, "Can I go to that room? Can I go to that?" And I'm like, "Yeah, just put them in there." So now they're requesting certain things, and that's fine. That's fine. I think it has really worked out. This partnership has been great for patient care.
Thank you.
I think that's great. The one thing I just wanted to make sure something that you talked about, and it kind of goes back to that care planning that's happened, legislatively this year, is there were more than 8,000 people that were sitting in the queue for resources like HCE, CCE, the Med Waiver program. They have increased funding to decrease that list of people. One thing that I always advise, and especially this kind of goes to more, not the association, but my gerontology hat, right, is to say the sooner you identify when you're working earlier on in the care plan, is to provide them with that resource early to get on the list, because they could be sitting on that list for a year or greater, but it will be earlier on to the point they'll need that service by the time they get there, right? And so that part of that care planning journey that you do, I think one piece that would be great to add is making sure to get them on that list. And what they're now looking at is also criteria of severity, right? So somebody may be lower with just custodial needs, but somebody may need more personal care. So they'll look at those levels, just like you were looking at them for your own patients. Like, okay, I see them average 6 months. Nope, I need to now start seeing them every 3. So they have criteria that lets us know that they're more at risk, and it will bump them up. And so I just want to make sure that they are seeing that, and that they are making more accessible to the population.
I think that's a great idea. Now, there's a couple of barriers that I've had over the last year. Council for the Aging in Tallahassee. There's a few patients that I've referred there that have my older population, physical disabilities, polio syndrome, they're wheelchair-bound quads, and so they need some special services. And what I've been told when I call the council number and make sure they're on the list, referring them because they've been waiting for a year, is that the patient has to request that. That did not make sense to me. And of course, the person I'm speaking with is just somebody who answers the phone, and they can't really tell me why that as their provider, I can't make recommendations that they need to be moved up on the list, or so there's kind of some confusion with that process.
Yeah, I was meeting with the area agency on aging director this morning. I don't think she'd be happy to hear that. I don't think that's right. That is really good to know. And I promise I'll follow up with that immediately and try to get you some answers, because that is the kind of one-stop shop to get access to services. So I'm glad you're aware of it and you're calling, but yeah, if it's not getting anywhere, then that's not helpful. So yeah, I can follow up on that. Thank you.
And some of this could be specific to my area. We are an hour, 30 minutes from Tallahassee. We're an hour, 30 minutes from Panama City. We're on the coast. I have a lot of trouble, even with my home health agencies, physical therapy, speech, OT, getting these services for my patient. Some of the, I only have like 2 home health entities here, and groups like Sunshine and Stay Well, they don't take them. I've got a geriatric patient who had a gastric perforation. He was urgently in Bay Medical, digestive disease, saw him there. He ended up with a J tube, a jejunum tube, which is further down in the GI tract, nothing oral. So this man's been on a tube feeding. I saw him post-hospital discharge. He is lost. He's down to 99 pounds. I am frantic when I see this patient. This is your only nutrition. You're not getting enough nutrition. You know, your blood sugars are. So I'm calling digestive disease. Do you have a dietitian? We need to look at his calorie intake, and we need to supplement. We need to change formulas. We got to do something. They don't have one. So I called his insurance. I need to refer him to a dietitian, to somebody pediatric. They have no adults. I still haven't found one. This has been a week for me, trying to figure this out. So it's just really, there's a lot of barriers to service.
Yeah, that's tough. I do have to sign off for 1 o'clock, but I thank you, everyone, and thank you for your comments, Doris.
Mm-hmm.
And we'll send the recording, and then I will send the information over to Nicolette and get you some links, okay? Mm-hmm. Thank you so much for your time, and thank you so much, Dr. Clough.
Pleasure. Thank you all.
I appreciate everything you do for your patients. Thank you.
Thank you. Bye-bye.
Thanks.
Bye.
Take care.